Hello, welcome to the Kansas State Veterinary Diagnostic Laboratory YouTube channel. This presentation discusses bovine clostridial disease part 1.
Okay, well, thank you very much, Dr. Anderson, Dr. Hezicek, Dr. Luber, for inviting me here. It is quite a bit of fun to go to different places and give talks and try and one, help teach a little bit, but also I'd like to also say that often when we go give talks at other places, we get information back. And so one, as I go on with these talks, love to go ahead. If you have any questions, just feel free at any time to raise your hand on up, speak up. I'll try and keep an eye out for it and ask the questions or comments if you have. Clostridial diseases has become a very interesting topic for me. One, because we do see quite a few cases in Colorado, and I'm sure you do here, especially those of you, I'm going to guess many of you do some amount of beef work. And so the Clostridial diseases in calves still a pretty important disease, and yet there's not really active research going on it across the country. And so a lot of the things that we put together as far as how we deal with these diseases and how we take care of them really come from trying to piece some different information, some from the human side as well as from the veterinary side, and trying to piece that stuff together and try and make at least what makes sensible ideas for diagnostics and treatment with the things that we have available, even though we don't have a lot of good research showing efficacy on some of the treatment things. So we're going to try and put all those perspectives together. And one of the things I'm going to focus on these talks today through the clostridial diseases is really spend some time focusing on the toxins. Because one, you as veterinarians, like me, probably sit there and go, okay, I may not be able to use the information that says that this toxin specifically inhibits this protein or is a protease for these proteins. But still, your curiosity wants you to know and say, oh, I understand that a little bit better. And who knows, down the road, there may be treatments that come along that are specific for how that toxin works that we can put into use in veterinary medicine. So we're going to spend some time on the toxins and then on diagnostics as well as then on treatment and a little bit on prevention for all of these diseases. Today, I've probably got more than I can cover today. We're going to start with the enteric clostridial diseases. And then we'll move from there and go into neurotoxic clostridial diseases and then also histiotoxic clostridial diseases. So if I get through all of this in 3 hours, it'll be pretty amazing. The notes I've got written notes for you that are pretty complete. And so much of the information will be in there. But then hopefully this will augment that as well. So we're going to start here with clostridial or enteric clostridiosis, enteric clostridial diseases. I love this sign. I was back up at this area not too long here. And I like the dichotomy here. Going beyond this point may result in death and or loss of skiing privileges. Now, I always wondered, well, why do we need to lose our skiing privileges if we've passed away? But it's a nice, this is up at Grand Targhee, it's on the western side of Wyoming, just right on the border between Wyoming and Idaho. That's a nice ski place. I have a few more pictures of Grand Targhee coming on up. All right, here we go. Neurotoxic clostridiosis, the two big ones, tetanus and botulism. We'll speak about those. Histotoxic clostridiosis, blackleg, malignant edema, necrotic hepatitis, bacillary hemoglobinuria are going to be the four that we'll spend some time on. And then all the enteric clostridiosis. And I've listed here all these various names that are used for all of these enteric clostridiosis diseases. And unfortunately, a lot of this goes with history of how these diseases were described, both in the United States as well as in Europe and other countries. But it really becomes very confusing, and often it also becomes confusing because enterotoxemia is often used as one single term that describes all of these Clostridium perfringens diseases. And so we'll try and break that down a little bit, but as I work through these now, for me, I find it easier just to think of the different Clostridium perfringens types and where they're seen and what they can cause. So we'll focus probably a little bit, well, definitely more on cattle here, but all of the principles we're going to talk about are going to be similar, whether we're talking about beef cattle, dairy cattle, sheep, goats, and even to some degree camelids as well. So we'll run on through that, and all the same syndromes can really be seen in any of the species. Clostridium perfringens. As you know, it's an anaerobic. There are some of the types that are more aerotolerant than other types of Clostridium. So they aren't all absolute anaerobes. They do grow best in an anaerobic environment, but they can have some amount of oxygen tolerance to them. They're gram-positive rods, very easy to identify, at least your suspicion of them on cytology, as we'll show here in some of these other slides. They do form spores when they are exposed to oxygen, or if they're exposed to an environment where they don't grow as well, they're going to go ahead and sporulate. The spores can survive a long time in the environment. They are ubiquitous. Enteric organisms definitely run through the GI tract, and they are distinguished by their toxins. So we have 4 major toxins, the major lethal toxins: alpha, beta, epsilon, and iota. As I say, we'll get into more detail on this, but alpha toxin, it's a phospholipase and has lecithinase and sphingomyelinase activity. We'll talk about all those terms. Even to me, I go, what the heck does that really mean? We'll talk a little bit about where those enzymatic activities occur and what it means from the pathophysiology standpoint. Beta toxin is a cytotoxin. It actually forms pores in the membrane. We'll show some diagrams of that. Epsilon toxin is also another cytotoxin, particularly targeting the vascular endothelium. And then iota toxin is this ADP ribosyl transferase. It actually ends up targeting the actin cytoskeleton inside the cells. And so it's going to disrupt that, and that's what causes the cell death. So these 4 toxins, because they're the primary lethal toxins, there are some other toxins involved in Clostridium perfringens, but because they're the primary lethal toxins, they're the toxins that we think of as targets for antigens and protection by immunization. Here's the breakdown of the different types and how they're classified based on their toxins. As you can see here, all types will carry the alpha toxin. We'll go over that in the next slide a little bit more. Beta toxin is carried by type B and type C, and then the epsilon toxin is in both type B and type D. And I'll just forewarn you here, in one of the later talks, we're going to talk about a mistake that's actually in your notes relative to this, and we'll get that corrected in your notes as well. Lastly, type E has over here iota toxin. Type E, it's been reported a few times in the United States as far as outbreaks of disease, but it's really considered pretty uncommon, at least in the United States. So most of what we talk about will focus on these top 4 here, types A, B, C, and D. One way to remember, and I'll put this in here as we go on later and talk about vaccines. So when we talk about Clostridial perfringens type vaccines, we have type C and type D. So our Clostridium perfringens, C and D toxoids. And the toxin that is the primary immunogens in those vaccines is the beta toxin and the epsilon toxin. And this will come on up as we think of what we're seeing now. Even though they carry the alpha toxin gene and they express alpha toxin, when these vaccines typically are made, it seems that there tends not to be much alpha toxin in the toxoid prep. And so we don't get much activity here. So C and D cover the beta and epsilon. Because they cover beta and epsilon, they also provide some immunity for type B as well, infections. So that's how the vaccines kind of go together and what they protect. As you can see here, if we don't get immunogenicity against alpha toxin, we don't have much protection against type A infections. All right, there are some other additional lethal toxins that are described. There's the enterotoxin and the beta-2 toxin. Those are important toxins. Enterotoxin is really an important toxin in human food poisoning. And it's interesting. It does cause pore forming, or has pore forming ability on the cells, will disrupt the cell membrane, and then the cell bursts. Oddly, the enterotoxin, as we'll get on into, it isn't normally produced in the vegetative growth stage of the bacteria. And where this comes into human or into animal disease, it's really not certain how big of a role it plays in animal disease. Beta-2 toxin has also been described. It also forms pores. It is not necessary for lethality in these organisms. It may provide some additional virulence to the organism, but that really hasn't been demonstrated well. And then there's some other toxins here. Of these, probably the theta toxin is probably most important. It is a hemolysin. It will disrupt red blood cells. It is found in many of the Clostridium perfringens type A isolates. And again, we don't have vaccines against it, but it is there and plays partly a role in the pathogenicity. Okay, so let's just go on back. You've had an animal. You thought it had Clostridium perfringens. You go ahead and say, I want to know more about this. Say, you know, did my vaccine not work that we've been vaccinating against, or is this type A? Where am I going to go with this? And ultimately, it comes down to saying, I need to try and get this isolate typed on out. Used to be that the method for typing isolates was to grow them on up, take the supernatants that had the toxins in them, and then go ahead and expose mice that had antibodies to the different toxins and try and identify which isolate you have. Now, with all of the molecular work, we've got PCR typing, and I'm going to guess that most of the veterinary diagnostic labs do this, and I'm sure that you do this here at Kansas State. And basically it goes through and it types for the alpha, beta, epsilon, and iota toxins. Many of the multiplex procedures also look for the beta-2 toxin and the enterotoxin as well. So a wide variety of different things. And if you go through and you look at these, you can see here's a isolate right here that's got the alpha toxin in it and the beta toxin in it. So you come over here, we're a type C. And then you can go and look at the same thing. Here's alpha toxin, beta toxin, plus the beta-2, so type C plus beta-2. Here's the alpha toxin and the epsilon toxin and the beta-2, so it's a B plus beta-2, and so on. Here's just the alpha toxin plus the beta-2, so a type A plus beta-2. And again, those are readily done. And this is the way you'd get your organism typed on out once you have a culture. Here's the genome, the chromosomal genome for Clostridium perfringens. The only reason I throw this on up here is to distinguish here this difference between where are the toxins located. Are the toxins located on the chromosome of the bacteria, or are they located on the plasmid? And why that makes a difference. Well, first off, alpha toxin is up on the chromosome. It's right here. PLC gene is the gene for the alpha toxin. And so it's stable on the chromosome for all of these isolates. Enterotoxin is interesting because enterotoxin in the human food poisoning isolates is actually on the chromosome of the organisms that cause human food poisoning. However, in the animal isolates, it's almost exclusively on a plasmid. And you'll have some human isolates that have enterotoxin, but it's on a plasmid. And those isolates in humans do not cause human food poisoning. So it's kind of an interesting difference for the enterotoxin and how it works and where it causes disease. All of these other toxins, the beta toxin, iota, epsilon toxin, are all on plasmids. The interesting point about that is plasmids can shift. They can move from one Clostridium perfringens to another Clostridium perfringens. So the plasmid is what really is determining what type of Clostridium perfringens it is, where you have the alpha toxin as the base core, and then you get the different plasmids that determine which type of Clostridium perfringens you have. Okay, alpha toxin, as I said, it's on the chromosome, it has phospholipase C and sphingomyelinase activity. So think of your cell, see the cell membrane. Phospholipase C activity is going to act on the phospholipids. Hydrolyzes the phospholipids in the cell membrane. Think one step further now and think of your physiology. What happens when we break down those phospholipids? Well, they go on to arachidonic acid and they start the arachidonic acid cascade. Alpha toxin does result in not only disruption of the lipid bilayer on the cells, which results in cell disruption, cell death, but it also starts the inflammatory cascade with prostaglandins and eicosanoids. And that's part of the mechanism and part of something I think we can deal with when we think therapeutically on how to treat these. All right, so we have the cell membrane disorganization. It is hemolytic, so alpha toxin by itself can cause hemolysis. This is more commonly seen in sheep for reasons that are not described. But you will see hemolytic crisis and icterus sometimes in lambs that get type A infections. Dermonecrotic, lethal for excuse me, many types of cells. Variable pathogenicity because of variable expression. Some organisms, some type A isolates will express more alpha toxin than other isolates. And it's both due to the genes that are around it that signal the expression, as well as just individually the conditions that it's being grown in. A study that Dr. Van Meter did at Colorado State looking at isolates from hemorrhagic bowel syndrome, one of the interesting things that he found is that type A isolates from cattle with hemorrhagic bowel syndrome had greater alpha toxin production than the type A isolates that came from just healthy, normal animals. So there is some suspicion that the variable expression can make a difference in the pathogenicity of the isolates. These alpha toxins are very susceptible to proteases. And another thing that I'll point on out when we go and think about vaccine manufacture is the alpha toxin is predominantly produced during the logarithmic growth phase of the bacteria. And when we get on up to the stable growth phase, alpha toxin expression seems to be reduced in many isolates, and the beta toxin or the epsilon toxin are produced more at this stable phase. When we think of vaccine production, most of the vaccines that are produced for C and D or 7-way vaccines take the broths up at the stable culture level. And this is at least my understanding, most people's understanding of what the biological companies are how they're putting these vaccines together. And so at that point, alpha toxin is decreased in production. Beta toxin, epsilon toxin are up. Also, the Clostridium perfringens itself makes other proteases, and those proteases that it break down the alpha toxin. So at the time these toxoids, broths are being collected for making toxoid productions, beta toxin, epsilon toxin are at high levels, alpha toxin is at low levels. So we see very little immunogenicity against alpha toxin in those preps. The only exception to that would obviously be the Novartis product, which is their type A or alpha toxin toxoid that they have that's specifically manufactured to maximize alpha toxin productivity and alpha toxin toxoid expression. Okay, more about alpha toxin. It has this lecithin ACE activity. Again, getting to the point of the arachidonic acid cascade, making thromboxane, prostaglandins, leukotrienes, all these inflammatory mediators that potentially are bad for us. Some platelet activating factor goes along. This is interesting here, and it comes up more when we talk about histiotoxic clostridiosis. But when you have platelet activating factor and you activate your platelets, what's going to happen? Well, you get thrombus formation in the area of the infection. What's thrombus formation going to do relative to blood supply? It's going to decrease blood supply. This is one of the mechanisms by which the ischemic or anaerobic environment in the tissue can expand, is because of this platelet activating factor and thrombosis of the blood vessels that can occur and allow that environment to expand so the vegetative organism can grow to more tissues and keep expanding in its distribution. Okay, so this was from a paper here in Journal of Biochemistry looking at the alpha toxin action. Any biochemists in here? My undergrad was in biochemistry. I still love this sort of stuff. Don't get to dabble in it too much, but I like the pictures. It's got a carboxy terminal domain that binds on into the lipid bilayer here, and then the N-terminal domain. And this N-terminal domain is the portion that has the enzymatic activity that breaks down the lipid bilayer and results in disruption of the cell membrane. Inside alpha toxin pathways, a lot of things are going on into the cell, but the thing again that I really want to point out is we do get thromboxane production and arachidonic acid cascade and that whole inflammatory pathway there as well. So a lot of things are happening inside those cells. Okay, beta toxin, it's carried on a plasmid, pore-forming activity, disrupts the cell membrane, so the toxin comes along, attaches to the cell membrane, groups together, forms a pore there, allows electrolytes on out, allows fluid on in, and we get disruption and cell death. It is cytolytic, and another really important concept here is it is rapidly inactivated by trypsin. Where does that come on in later? Okay, that comes on in again. When do we see type B and C infections predominantly? And the bit here is that trypsin inhibitors will preserve the activity. So if we have Clostridium perfringens type B or type C with the beta toxin in the GI tract, they'll be producing the beta toxin, but normally there's sufficient trypsin present that the trypsin will immediately degrade the beta toxin and it won't be effective. It'll neutralize the toxin. However, if trypsin inhibitors are present, then the beta toxin will persist and cause the damage. The most common source of trypsin inhibitors is from colostrum and early milk from the dam. So when we look at disease caused by type B and type C organisms, it is most common in the first 10 to 14 days of life for the calf or the lamb or the kid or whatever. So this is the primary reason why, is this trypsin inhibitors that preserve the activity in that case. Epsilon toxin is the other really major toxin we should be thinking about. Again, it's on a plasmid. We do get post-translational proteolytic cleavage that activates the toxin. So it comes out as a bigger protein. Portion of it gets cleaved on off. And trypsin is what activates it. Binds to the cell membranes, form a complex, and again alters the membrane permeability, results in cellular instability and cellular death. As I mentioned before, this toxin predominantly has its effect on endothelial cells. And the other thing that's different about this toxin when we compare it to our other Clostridium perfringens that cause enteric disease is that this toxin is very readily absorbed systemically. So with type D enterotoxemia, the epsilon toxin, and to some degree with type B enterotoxemia, the epsilon toxin is absorbed, gets into the vasculature, and throughout the body it can cause this effect on the endothelium. We tend to see the lesions in the liver, the kidney, and the central nervous system predominantly, especially in the central nervous system with the symmetrical encephalomalacia that's seen there. And if you go and look at the literature and everything, and even as we teach it to veterinary students in class, we teach this classic enterotoxemia, overeating disease as being the type D disease, epsilon toxin, and neurologic signs and sudden death. The other aspect to think about here as we go through, when we think of the beta toxin and the alpha toxin working locally at the site of infection or the site of toxin release, epsilon toxin's absorbed, gets into the blood, and goes systemically. When we think of trying to neutralize it with antibodies, we've got to do two different things. For epsilon toxin, if we've got IgG humoral antibodies in the blood, it will very effectively neutralize this toxin and stop its effect on the endothelium. If we've got antibody for beta toxin or alpha toxin in the blood, and we've got the organism growing in the GI tract, and we've got the mucosal barrier between the organism and the antibodies, the organism is going to release that toxin. That toxin's still going to have a direct effect on the mucosal epithelium. And until there's sufficient damage there that allows plasma leakage and antibody leakage on into the GI tract, we may not get a really good protection from the humoral antibody. So taking this a step further, when we think immunologically, how are we going to deal with this? If you have Clostridium perfringens type B or type C, and you're looking at the beta toxin, you're going, all right, well, where do I need that antibody? I need that antibody down in the GI tract. So active immunity of that calf and producing IgG, not going to be as helpful as passive immunity in the colostrum and contained in that early milk of the dam for that first, again, 10 to 14 days. Because they're ingesting that colostrum orally, it's going to neutralize the toxins in the GI tract. And there we're going to see a really, really good response. And we only really need to worry about it for about the first 2 weeks. So it all fits together, and when you look at how do you maximize protection, for type Bs and type Cs, maximize protection by vaccinating the dam, colostral antibody, protection inside the gut lumen. For type D, maximum protection either way, maximize get the dam, absorb the IgG and get protection, or active immunity in the calf to get humoral immunity. Iodotoxin, again, it's type Es. These are very, very rare isolates, it seems, in the United States. Carried on a plasmid. It's a large toxin, acts at the cell cytoplasm, where, again, it breaks up the formation of the actin filament and breaks up the cytoskeleton. That's about all we're going to say about iodotoxin and type Es. Enterotoxin, I already mentioned some things about that, about the differences in human food poisoning cases versus the non-food-borne human GI disease or the animal GI disease. The gene can either be chromosomal or plasmid. Inconsistent in animal isolates, but then again, we've got this interesting thing about it in that it is only produced during the sporulation phase. So when the vegetative growing bacteria gets in an environment where more oxygen, doesn't like the nutrients there, it's going to start to sporulate. As it starts to sporulate, it starts then producing enterotoxin. And then at the final stages of sporulation, the rest of the bacterial cell breaks down and releases this as an exotoxin. So it's released with lysis at the end term of sporulation, and all that's left is the spore, and the toxin comes on out. Does form pores, it is cytolytic, can be carried in all types of Clostridium perfringens, but again, in the studies that have been done in animals, it's uncertain how big of a role it actually plays in the diseases that we see in livestock. Beta-2 toxin, plasmid, limited homology to the beta toxin, although it does probably work by a similar sort of mechanism of forming a pore. It is cytolytic. It is not necessary for lethality or disease. And again, in the studies that have looked, when you add beta-2 toxin to an isolate, does it increase virulence? It doesn't seem, those studies have been pretty inconclusive. So I wouldn't say that it's really necessary. If you were working with a herd that was having a Clostridial problem and they wanted to make an autogenous vaccine, if I had the choice between an isolate with or without the beta-2 toxin, I'd go ahead and take the one with the beta-2 toxin. But I've had one herd that, we may talk about this a little bit later, but has been using for probably 6 years now autogenous vaccines for problems with hemorrhagic bowel syndrome, so in dairy cattle. And in that herd, for those of you who've made or worked with companies to make autogenous vaccines, you'll know that your isolate will only be good for a set number of years. The FDA limits how long they can make a vaccine from that isolate. And so you get to the point where they say, okay, we can't make it from this isolate anymore. You have to wait for a case, and then you get a case, you isolate out a new organism, send it on in, and they'll start a new vaccine. So in this one herd, we started out with a type A with beta 2. Actually, it was a type A with beta 2 and enterotoxin. Used that vaccine for a while, ran out of time on that one. Needed a new isolate, got the next isolate. The next isolate was just a type A without beta 2 or enterotoxin. We couldn't see any difference in efficacy of the vaccine, but that'll get to another question later, where is the question, can you show any efficacy of a Clostridial vaccine with hemorrhagic bowel syndrome anyways? So we'll discuss that maybe a little bit later. Okay, theta toxin. I'm going to skip over this one. It's there, but we don't vaccinate against it, and so we don't particularly look at it. This diagram just puts all the different toxins together and where they work. Alpha toxin, as far as disruption of the pore. Beta and beta 2, again, probably forming pores in the lipid bilayer. Epsilon toxin, again, pore forming and electrolyte transfer in between. Theta toxins, also pore forming. Enterotoxin, disruption of the lipid bilayer. And then also the iota toxin, which gets internalized and causes disruption of cytoskeleton inside the cell. So lots of things going on there. Good biochemistry. A few snow pictures. Better than being in Boston this morning, I would say. This is, there's the Grand Tetons. Again, looking off the backside of Grand Targhee on one of the few sunny days that you'll see in the winter in that area of the country. Okay. Disease syndromes. These are the various names of the disease syndromes. They're in your notes in a table there that go with the different types. I personally find them less useful as far as how I clinically approach this. And more important is realizing and understanding what type of organism you have, and then what the toxins are and how you're going to try and address those toxins. Okay, so the disease of type A. So we're going to go through now, and we're going to take a break, and we're going to look at type A, a little bit about type B, type C, and type D. Go through those diseases real quickly. And for type A, enterotoxemic jaundice or yellow lamb disease. Remember I told you that the alpha toxin can cause hemolysis. So it's seen in lambs most commonly, depression, anemia, icterus, hemoglobinuria, if you see them alive. Well, if they're dead, you'll see these aspects too. The alpha toxin does cause some of the hemolysis as well as the cell death. Death is often very rapid with all Clostridial diseases, or can be very rapid. And dietary factors are thought to be an important aspect in these. Probably, again, high concentrate grain diets. Also, when they're nursing, disruption in the feeding patterns that can result in a high milk intake for one feeding may also predispose animals, the lambs, to this. Rare in the U.S. as far as this disease syndrome. Some reports out of California. What we probably all here have experienced a lot of is going to be the situation of abomasitis and enteritis, whether it be in calves or in sheep or in goats or even in camelids. We probably definitely see 1 to 2 of these cases come into the hospital at CSU per month. They're fairly common, especially from our dairies, but we see this with relative frequency. And I think the biggest thing is recognizing the cases. We'll show some pictures coming on up here for beef and dairy cattle. The biggest thing I find is the abdominal tympany. I think, again, you guys probably already all know that. You see that calf, it's got that abdominal distension. If you put the stethoscope on it, it sounds like a drum beat to it when you try and ping it. Sometimes they'll have a classic ping, just like an adult cow can have a classic ping. Very tight abdomen. Often that abdominal distension, because of the distension of the intestines, putting pressure up on the diaphragm, so they have difficulty breathing and have some amount of respiratory distress. You may have abomasal ulceration with these when you see them at necropsy. We'll show some pictures of that. you can, instead of seeing this abdominal tympany and abomasitis aspect to it, even in adult cattle, you can see what appears to be a hemorrhagic enteritis. That they'll tend to have a little bit of a distended abdomen, especially down ventral right, because it's mostly an enteritis, and that the small intestine is going to develop ileus, it's going to dilate, and you'll look at that, and if you look at it with ultrasound, you'll see the dilated loops of bowel down in the ventral right where everything's just stagnant. And then often with these, you'll get hemorrhagic diarrhea with those as well. And then there's the hemorrhagic bowel syndrome. As I say, we're going to take a break. I don't have any more slides in this presentation about hemorrhagic bowel syndrome, but we may take a 5-minute break at some point here and just talk and see if you have any questions that I probably can defer and say no one knows the answer to that. There is some evidence that Clostridium may be involved with hemorrhagic bowel syndrome, but it's hard to prove that it's a cause. Dietary factors, carbohydrate and protein in the diet. The protein type may be a factor here. Milk quality, bacterial overgrowth in the milk, so dairy. They're taking bulk tank milk, they put it in drums, the drums sit for 12 hours, the Clostridium overgrows in the drums of milk, they go feed it to the calves, calves get Clostridial disease. Alternatively, with milk quality or milk replacer quality, it can be mixing problems. You go through and you mix up your milk replacer, and by the time you start feeding the first calf out of this drum to the time you feed the end calf, you may have some settling of the milk replacer in there, and you have different concentrations and different osmotic osmolalities of the milk replacers. And osmolality of milk replacer has an effect on gastric emptying time. So when we think of this disease, basically I think of two things need to happen to get the Clostridium growing. Number one is they need to have the resources, either carbohydrate or protein, for the resources, for the nourishment, for the organism. The second thing is something else that is causing some ileus. And that could be cold milk instead of feeding warm milk. It could be an altered osmolality of the milk replacer. It could be other ongoing diseases. It could be an underlying coronavirus that's otherwise subclinical, an underlying rotavirus that's subclinical, an underlying crypto that's subclinical. In camelids, coccidia and Clostridium go together. So you can get coccidia infections and you'll get Clostridial overgrowth along with the coccidia infections. So I tend to think of these that something else has caused some ileus. We also have the carbohydrate and protein load and allows for overgrowth. And I also think the same thing happens to some degree in the adult cattle that get this disease, whether it might be improperly fermented silage and they get into a bad pocket of silage, maybe some aflatoxins in it or other mycotoxins in it that may alter GI motility and set up the opportunity for overgrowth and start this whole thing going. So I think that's a really important part, and it's going to be nebulous for a long time as far as exactly what those factors are, but it really comes down to the better we can feed our animals and the more consistently we can feed our animals, the less likely these diseases are going to be. Okay, so abomasal tympany, things that can cause it. Beef, okay, storms. Udder's full after the cows and calves hunker down. Storm blows on through. Cow gets on up. Calf says, oh man, I'm hungry now. Cow's got lots of milk on in there. They nurse a lot. And you see these little mini outbreaks of Clostridial cases. They're still sporadic. There's still only a small percentage of animals on that given day. But on any time this comes on through, you're potentially going to have a few calves that are susceptible to Clostridial overgrowth. Spring pasture blooms set up the opportunity for the cow all of a sudden to make more milk. She makes more milk. The calf's still vigorous. The calf says, I'll drink it. If you got it, I'll drink it. And gets a little bit more milk and goes ahead and sets up for Clostridial overgrowth. Intermittent provision of range cubes have been anecdotally described by both producers and veterinarians that they throw out a bunch of cubes every so many days. Cows go tank up on the cubes, they make a little bit more milk, calf nurses a little bit more milk, or maybe there's more protein. Who knows what the exact factors are, and we get some Clostridial breaks. So great chance here for the beef cattle people on out here. Do you see these sort of things? Do you have some others to add to it? Greg's nodding his head. I think a few. How many see these sort of things happen with the beef cattle and calf? Yeah. So I'd say almost half of you raising your hands and saying, yep, we associate those with Clostridial disease. Dairy. Whole milk and milk replacer can be involved, especially milk replacers and some of the high protein milk replacers. As I say, mixing is critical with those milk replacers, that you get even mixing throughout and it stays mixed as you go through and feed all of the calves. High osmolality milk replacers will decrease gastric emptying. Cold milk replacers may decrease gastric emptying. Again, look at that sequence and what's the sequence of their feeding and where is the disease happening in that sequence of feeding through the calves. Inconsistent milking, and then contamination. Going back to the contamination, one of the more interesting cases, or the deja vu cases that I saw in the hospital, first came the calf. Calf comes on in, calf has obvious Clostridial enteritis. It's a beef calf. From a particular owner, and we just go, gosh, we usually don't see Clostridial diseases from you guys, and go, this is really kind of interesting. And when they brought it in, they just brought in the calf. They didn't bring the cow on in with her, and so we took care of the calf, started treating the calf. The next day, they brought the cow in and said, hey, doc, I think you need to look at this cow's udder. Go and look at the udder. Sure enough, she has mastitis. So then we go and say, well, that's interesting. So we go and take a milk sample out of that, make a gram stain on it, sure enough, full of a bunch of big blocky gram-positive rods, put it in through the culture, and she's got a Clostridium perfringens type A mastitis. So here was a situation where she probably developed that mastitis first, then the calf was nursing this dam, got the Clostridium from her, a very high load of the Clostridium, and set up for the Clostridial enteritis infection in the calf. They both did survive, but sometimes these can be really tough cases. Yeah, Greg.
Do herds that use the accelerated calf feeding programs in areas, are they at higher risk of this?
It still comes down to management. So on the, okay, the question is do the herds that use accelerated calf feeding management, so again, they're going to use the high protein, high carbohydrate calf milk replacers, put them up on the bars so that the calves can nurse as often as much as they want to, is probably most common. Now, so on the one standpoint, so it's really tough management on these. First thing about management is consistency of your mixing and worrying about settling out of your milk replacer. And different brands of milk replacer probably have different risks involved there. Some are going to mix and stay suspended better than others. Second aspect of that, though, is initially you think, oh, well, if we've got free choice milk for these calves all the time, that they're potentially at greater risk. But the other thing that goes along with that is these calves are nursing more frequently with smaller volumes. And more frequent feeding of smaller volumes was probably a decreased risk of getting Clostridium perfringens. So the unfortunate answer to you is yes or no. Ones that are managed really, really well don't seem to have a bigger problem. Ones that aren't managed so well, they don't clean the equipment as well, Clostridial overgrowth in the equipment, they don't mix as well, the temperature's not right, it gets too cold between when you add milk. All those sort of things can factor into it. Do you acidify the milk replacer before you feed it that way or not? All those things go in. So accelerated calf feeding programs need to be managed extremely well, and when they are managed extremely well, any of you who have worked with those calves blossom and do terrific. If they aren't managed really, really well, you can have horrible wrecks. Is that experiences you've seen too, or? Okay. So here's a typical, there's a beef calf. You can see that belly. This calf needs some help. We'll show you that calf again a little bit later. Okay, that's enough of type A. Any questions on type A? In the last 10 years, since I've been really focusing and culturing these calves that come on through and typing these on out, I have only cultured, from the calves we see come into our hospital, I have only cultured Clostridium perfringens type A. I have still, at this point, yet to see a type B or a type D cultured from our calves. Now, Dr. Songer down in Arizona, I'm sure many of you know him. He's probably nationally regarded as probably the livestock Clostridial expert in this country. He still will report some B's, C's, and D's, but he'll also say, yeah, they're much, much, much more rare than type A's. So if we get into type B's, again, lamb dysentery, not seen much in the US, reported more in other countries. Again, it's up to 3 weeks of age, but I'd even say realistically you're down 2 weeks or less in these animals. Hemorrhagic dysentery, calves, can occur in foals as well. And then classic hemorrhagic enterocolitis. This disease, because of the beta toxin in this organism, you get much more, or it seems that clinically we get much more of an erosive mucosal barrier that hemorrhages, and you see, and it may be a little bit more distal, rather than being the abomasitis, it's more of a enterocolitis, as the name says there. And so we see the blood coming out in the feces sometimes before the animal passes away. Type C, also hemorrhagic enterocolitis. Calves in unvaccinated situations could be fairly common. For our hospital at Colorado State, this organism, as I say, I haven't found it in a calf since I've been there, but we'll pick it up now in some of our foal Clostridial cases. So I think the biggest thing here is when you look at what's the vaccine done, vaccine's done a really very good job at limiting type C, type B, and type D infections, and at least really protecting them when the vaccine's used appropriately. Soil and feces, calves, let's say beta toxin, up to that 10 to 14 days of age. The trypsin inhibitors in the colostrum and the milk are really important at helping to allow the toxin to persist and cause its damage in that early time. Soy, sweet potatoes can have trypsin inhibitors in them, so if they're being fed, but again, this isn't something you'd typically be feeding to a calf, so it's not something there in a calf. Potentially could allow this organism to overgrow in an adult animal, but unlikely. Immunize the dam, that's the key on this one. The colostrum, the antibodies in that early milk are going to be what's really protective for these calves. Clostridium perfringens type D, the classic enterotoxemia, pulpy kidney disease, overeating disease. This is the one that tends to predominantly show the neurological signs because the epsilon toxin is going systemically and affecting the endothelium and causing that, the brain damage. So endothelial permeability, we see intestine, renal, hepatic, and CNS vasculature effects and the systemic distribution. The other interesting thing is this hyperglycemia. It is fairly common, not really pathognomonic, but fairly common with type D infections in calves. It's mobilization of the glycogen from the hepatocytes, and you'll see both the hyperglycemia and glucoseuria. So if you suspect a case, it's a necropsy, pull a little urine sample out, put it on a dipstick. If it's got glucose in it, it would lead you towards suspecting Clostridium perfringens type D. Ages, usually this is going to be more of a weaning age, older age disease rather than the type Bs and type Cs, which are the younger animals. Sometimes seen in the calves that are from the heavy milkers, but more commonly when they get onto a high carbohydrate and or protein ration. Vaccinate the dam. The colostral antibodies are protective up to 8 months. And also, Immunologically, it gets into things about superantigens, but the maternal antibodies do not block response to the vaccine in the young calves. So the neonate is not inhibited by the colostral antibodies in forming an immune response to this. So you can vaccinate earlier in calves, lambs, kid goats as well, and get a good response there. We break at 10?
Yeah,
or
yeah,
okay.
I've got another question.
Okay, Greg.
What about vaccinating calves at birth?
I've got a slide coming up on that, and I'll tell you, so the question is, what about vaccinating calves at birth for the C and D vaccine or a 7-way vaccine? The D you'll get a response to, okay? So for the Epsilon toxin, the beta toxin, you may or may not, I don't know that there's any data on whether you get an immunological response for the beta toxin when you vaccinate calves at birth. The question really comes down to is, well, does it protect the disease? And here again, if we were looking at type D, if say mom's not vaccinated, vaccinate the calf at birth for type D, when its potential disease is when it's out at 10, 12 weeks, well, you got plenty of time to get an immune response and you're great. For type B and C, that disease is going to happen in those first 2 weeks. These are toxoids. You aren't going to get an immune response in those first 2 weeks. Then again, the last question is, well, what about type A? Well, with type A, we don't have really much alpha toxin toxoid activity in these vaccines anyways. But here's where I have a hard time with all of this, and I'm sure you do too, Greg, is because there's lots of veterinarians and lots of producers out there that swear by it and say, if I vaccinate my calves at birth, I see less disease, less bloody gut, less purple gut, less abomasitis, whatever you want to call it. And I've got to, I hear that so often that I go, there's got to be some amount of truth to that, but I don't know why. So it's an area that I think really does need further research, and we really need to investigate that. I'm going to blast through a couple of slides of the classic type D enterotoxemia. Here's the pericardium in the heart. You can see the pericardial effusion. That's one of the classic signs. Again, if you see that, you should be suspecting type D. The focal symmetrical encephalomalacia, where you can see these spots of grossly of necrosis within the brain. When you go ahead and cut them in cross-section, you need to cut several areas. Often they talk about thalamus, cerebellar peduncles, but just split it multiple areas and look for those lesions that may show on up. And I'm going to guess many people seen these, looked for them and seen one recently. Again, the vaccine works so well, we just don't seem to see this disease much anymore. Because you'll get some swelling of the brain and some edema of the brain. You can get herniation of the cerebellum, and so it'll come on out through the back of the skull there, and you can see that, and you can sometimes see a little bit of extra hemorrhage there. These were all pictures from, this is a wonderful paper, and if you want, even though it says sheep and goats here, it's still a wonderful paper. And I probably insulted someone out there with that. But, and if you don't have access to that, feel free to give me an email, and I can get that paper back onto you. But it's got wonderful pictures to it, great description. So you see Dr. Saunders on this, and really, really good paper. And then type E, as I say, it's out there. It's been described in goats, but really we don't. I've never seen this isolate and never seen a case of this. So one that I don't think we should really too much have on our radar screen. Okay, I think I maybe have a time for a question here, and then we'll take the break. Yes?
You stress vaccinating the dam in a lot of these issues.
Yeah.
So I guess my question would be, do you recommend an annual vaccination of the cow herd for Clostridial diseases every year? Or is there a cutoff period at a certain age of the
That's a terrific question. So the question is for vaccinating the dam, do we recommend vaccinating the dam every year, or can you back off on that and maybe go every other year, or even past a certain age she's been immunized sufficiently? Here's the trick, and this comes on up actually when we talk about any of our vaccines and our diseases, be it even bovine herpes virus 1, IBR, or BVD, and saying, what are we trying to get out of the vaccination? If we're simply trying to prevent or protect the dam, then often we probably get to a point where we vaccinated her enough that she herself is protected, that she'll have a rapid enough amnestic response that she can put out antibodies quickly enough. Now, in toxin diseases, like Clostridial diseases, that may not always be the case, because remember, an amnestic response is going to take about 4 days. So if her antibody levels have dropped, and now we've got a toxin, boom, she can be dead in 24 hours and hasn't had a chance to get an amnestic response. So with the Clostridial diseases, it is important, I do believe, that you maintain antibody levels in them. From the calf standpoint, I think that becomes even more important, because in the calf standpoint, they aren't already actively immunized. We can't rely on an amnestic response. And what we're trying to get to the calf is those antibodies in the colostrum, and we aren't going to have good levels of antibodies in the colostrum unless the dam has good antibody levels in her blood. So if I'm looking at types, Clostridium perfringens vaccination to protect the calf, I do believe that we should be vaccinating the dams every year. If I'm looking at IBR or BVD and saying, can I protect the dam? Probably after 2 or 3 modified live doses of vaccine, she's probably good for life. But the problem there is, again, while she won't get sick, what prevents the virus from going into the calf through the uterus is having sufficient antibodies to stop the viremia. So while a cow may be protected against overt respiratory disease, she may not be protected sufficiently against the viremia and the abortion that may follow. So you got to break those down and say, what am I protecting and what do I need to protect them? And generally, having consistently high antibody levels is important. Good question.
And to protect the calf in colostrum, it needs to be given at the right time, so the level is...
Yep, good point. So Dr. Anderson's comment here is to protect the calf, we need to make sure that the calf does get colostrum, gets it early, gets sufficient amounts at the right time, and has that available. Any other questions? I'll take one more, and then we'll take a break, and we'll get back. Let's take this one up here front.
What if you just give the C&D antitoxin at birth?
Oh, yeah, great question. So what if you give, the question is, what if you give the C&D antitoxin at birth? Will you get protection from that? You'll definitely get protection for the Epsilon toxin for the systemic one. The question is how much protection are you going to get against the beta toxin that, again, is in the GI tract when you give antitoxin? Because we're going to have IgG out here. Now, we know IgG is recirculated and slowly excreted into the GI tract. So there's a little bit of it that goes into the GI tract, but not high amounts. And when we look at the milk that's being taken in from the calf over the first 14 days, that milk provides a local enteric immunity as well as what was absorbed at the first 24 hours. And it's that enteric immunity of that antibody that's always going through the GI tract lumen that really neutralizes it. So you'll get some benefit from antitoxin at birth, but you get far more benefit from having it in the colostrum, in the milk, being administered every day that they nurse.
Thank you for tuning in to the Kansas State Veterinary Diagnostic Lab YouTube channel. If you have questions about this video or any of our services, please visit us at ksvdl.org.